to interpret the HbA1c in the era of CGM. So we all know that there are different methods of measuring glycemic control, like fasting, postprandial, random blood glucose. We sometimes use oral glucose tolerance test. And now with the help of continuous glucose monitoring, we are also looking into this. So where we can place HbA1c in this, we all know that glycosylated hemoglobin is basically a attachment of glucose to the hemoglobin. The N terminal of the beta chain of hemoglobin is having glycosylation, and this is depending upon the life cycle of RBC, that is hemoglobin in the RBC. So we all know that it is around 120 days. So it is measuring something like 2 to 3 months of glycemic control. There are different types of hemoglobin in our blood, and maximum 80% of this glycosylation is occurring in HbA1c part rather than on other HbA1 or HbA1b or A, all those. So maximum is utilized here, and we know that the clinical value of HbA1c is that it is an index of long-term glucose control, and it can be performed on venous blood glucose in without any consideration for time of the day, meal of the person, exercise or no exercise, or any time of the day, and whether it is not changing, because it is giving you a average of last 2 to 3 months of glycemic control. So the clinical value of HbA1c is that it helps in clarifying the discrepancies between the self-monitored glucose level and actual degree of overall blood glucose control. So many times our patients are measuring 1 or 2 or 3 values of SMBG, and they highlight that their glucose are controlled. But when we look into their HbA1c, we find that it is significantly higher. It also helpful in differentiating stress-induced hyperglycemia, which is sometime when the patient is admitted, particularly during COVID era, when the patient was first time detected hyperglycemic. We were not knowing whether he is a known diabetic who was not recognized earlier, or it is stress hyperglycemia because of stress of the illness or because of steroid treatment. So there you will find that HbA1c will be normal in a stressed hyperglycemic condition, except when the patient is a known diabetic earlier. So it is also useful in clinical decision making. What is the drug of you want to choose for that patient, whether the HbA1c is mildly raised or it is significantly raised, where you like to go for a combination therapy right from the beginning. It is also useful in our obstetric practice, where you can predict congenital abnormalities in a lady. When we look at the HbA1c, we all know a HbA1c of more than 10 is significantly associated with congenital malformation in fetus. And nowadays, we all know that it is also used as a diagnostic criteria for the diabetes. But we know that there are many ifs and buts with HbA1c measurement. There are some conditions where there is an inappropriate low HbA1c, like hemolysis, certain hemoglobinopathies, recent blood transfusion, acute blood loss, hypertriglyceridemia, and many drugs are also influencing it. Then there are conditions where inappropriate high HbA1c will be there, like iron deficiency, vitamin B12 deficiency, alcoholism, uremia, and many other drugs are influencing it. And then, of course, there are variable effects according to the fetal hemoglobin, methemoglobin, and certain other hemoglobinopathies. So whenever we are looking at HbA1c, we should know that these conditions are not there. Otherwise, we may have high or low HbA1c. So the drugs which are affecting HbA1c, we all know that there are some drugs which are causing increased erythrocyte destruction. Thereby, they are falsely lowering HbA1c, like dapsone, ribavirin, antiretroviral drugs, cotrimoxazole, hydroxyurea. There are other drugs which are altering the glycation, particularly vitamin C, vitamin E, and aspirin. And there are some drugs which are interfering with the assay of HbA1c. So dear friends, HbA1c era was there for the last, I should say, 30 years or so. And here, according to patient, he is getting main glycemic metrics as a HbA1c, guiding his therapy, and main metrics for rating the quality of diabetes care and medication. For physician, HbA1c tells us that it is a main diagnostic criteria, a standard marker of assess risk of complications, and target standards used to diabetic algorithm. For example, in ACE guidelines, they say if the HbA1c is less than 7.5, we may start with one drug. But if the HbA1c in between 7.5 to 9, you can start treatment right from the beginning with two drugs. So these are the algorithms which are depending on HbA1c. And for regulators, our health regulators, it is the main outcome marker for health authorities to approve a new drug, glucose lowering drug, and technologies for diabetes management. So we all know that there are available measures of glycemic control, and HbA1c is a good parameter in one of them. But CGM is now coming in, and as Dr. Panda highlighted, many important aspects of CGM: time in range, time above, and time below range. So the glycemic variability is an important consideration, and when you are having patients where those conditions where there is a falsely elevated or falsely low HbA1c values are coming, then of course we are handicapped. So HbA1c is not always a reliable marker of glucose control, but most of the studies earlier done on HbA1c are looking in, it is a gold standard for understanding and prevention of diabetes complication, like DCCT trial, and in UKPDS, the complications were directly linked to the amount of HbA1c. But because of these hemoglobinopathies and other changes, sometimes HbA1c is overestimated or sometimes it is underestimated. So despite HbA1c being a trusted biomarker, prevalence of so many common HbA1c hemoglobin variants in the country are causing an important challenge here. And another important field in looking into HbA1c is that sometimes we are having patients who are having a glucose profile like this patient A, and the other is having a patient B. The two patterns of glucose profile is highlighted here. Both these patients are having a HbA1c of 8, but in yellow markings, you find that there is a significant glycemic variability as compared to the red mark, where the glycemic variabilities are significantly reduced. So different patterns of glycemic variabilities are there in our patient's profile. In patient number A, there are so many high and lows in the glucose profile, but in patient number 2, the glycemic variability is significantly reduced. But the HbA1c of these two patients are similar. So the limitations of HbA1c is that it does not capture hyper and hypoglycemia. It does not capture the individual glycemic patterns in a day or in between the days of a patient, and it does not capture glycemic variability. And we find that HbA1c is a biomarker which sometimes is not giving you correct picture, as we discussed, but it is having a direct relationship to mean glucose, but there is a range of that mean glucose. And then, of course, if you look into HbA1c and you look into number of different patients, you find here on this right side upper panel that the patient's HbA1c is same, but the glucose, mean glucose profile may be changing in them, and then it is not giving you any clue about hypo and hyperglycemia, and having a limitation of looking into the instability, variability, and excess glucose exposure and hypoglycemia when you are only looking at HbA1c. So we all know that there is a oxidative stress according to the rise in blood glucose, particularly postprandial scenario, and these glycemic variabilities like hyper and hypoglycemic excursions may lead to so many other conditions, like it may lead to increased inflammatory markers and cytokines in causing increased vascular inflammation, increased production of reactive oxygen species, and leading on to increased oxidative stress. It impairs the release of nitric oxide and VEGF, and thereby causing vasoconstriction and impaired angiogenesis and increased platelet activation and aggregation. So all these things lead to endothelial dysfunction, increased thrombosis, and increased plaque instability, leading on to production of increased microvascular as well as macrovascular complication. So here you again see the same HbA1c but different profiles in our patients. So whether it is 8.1 in the upper range and you find 7 on the lower panel, but you find that the pattern is not similar. So according to CGMS, you have different patterns, but the HbA1c of these patients are similar. So HbA1c is not always a reliable marker of glucose, you can say, control. We need a different metrics in addition to HbA1c, because HbA1c lack the information about the acute glycemic excursions and acute complications of hypo and hyperglycemia. HbA1c failed to identify the magnitude and frequency of intra and interday glucose variability, and certain conditions, as we discussed, anemia, hemoglobinopathies, iron deficiency, pregnancy, and many other drugs may confound A1C measurement. And despite these limitations, A1C is the only prospective evaluated tool for assessing the risk of diabetes complication. And in most of the studies, it was linked to complications are linked to HbA1c. So again, you find that there are many phases of HbA1c here. The HbA1c is 7 in the 3 situation, but in right side, you have 100% time in range, but on left side, you find only 40% time in range. And people living with diabetes experience different energy levels, moods, and overall quality of life when they are in range versus when they are out of range. So time in range can capture these differences in a way where A1C is not. So what is the answer? The answer is CGMS system. And here Dr. Panda greatly highlighted it. We can get so many information with CGMS, like what is mean glucose, what is the glucose management indicator. I will highlight this GMI. And then, of course, glycemic variability. We want that glycemic variability should be less than 36%, but sometimes we find that it is very high. And then, of course, time in range, time above range, and time below range. So time in range was highlighted beautifully by Dr. Panda. It is a matrix of glycemic control. And we all know that time in range is the percentage of time that a person spends with their blood glucose level in a target range. It is a metric of glucose control that provide more actionable information than time in than HbA1c. It is a metric which includes 3 key CGM measures: percentage of reading in the time in range, time above range, and time below range. And CGM based glycemic target must be personalized to meet the need of each individuals. And time in range goes beyond HbA1c in representing blood glucose level, because it captures variations, and it captures whether it is high, low, and in range values, and characterize the life of a diabetic patient. So this thing was clearly highlighted by Dr. Panda, so I will not go into detail. But what is this time in range? As you can see here, time spent in a range of 70 to 180, from 0 to 100%. You can see how the different patients are having different time in range. These are the guidelines according to which we say that in type 1 and type 2 diabetic patient, we want that the patient should spend more than 70% time in time in range, and time above range should be less than 25, and time below range should be less than 5. And similarly, in patients with pregnancy and in patients who are gestational diabetes, different values are there. In pregnancy, the ranges are not 70 to 180, it is 63 to 140 milligram, and we want that the patient should spend more than 70% time in this range. So international consensus on time in range highlights that time in range delivers more actionable data than HbA1c alone, and time in range of more than 70% relates to an A1c of less than 7.5. So higher is time in range, lower is HbA1c, and time in range is a valuable blood glucose metric beyond HbA1c. And again, these things are highlighted by Dr. Panda, that higher the time in range, lower is the chances of developing retinopathy and microalbuminuria, and less are the chances of having macrovascular all-cause mortality and cardiovascular mortality if you have a better time in range. So standardization of this time in range is very important. CGM published recommendations for use of this ambulatory glucose profile. So the AGP is a type of app which is clustering all those things and giving us a very compiled, you can say, report. So AGP report is slightly modified format, has been adopted by most of the CGM devices, and it is a differentiator. Ambulatory glucose profile AGP is an innovative way of looking at the patient with diabetes to be enabled with ample information that gives insight into the daily glycemic profile of a patient and help in making well-informed decisions in context with diet, exercise, as well as medication. So the CGM is providing so many data, and we have to look into those data. It will be very tedious. So data must be organized to assist interpretation. And it is a simple proposal to simplify the data by employing such measures as time in range. And here ADA again highlighted that ambulatory glucose profile, what we say AGP, is very useful in compiling these data. So here you find that 1 day of CGM values are there, but how to look at it? AGP report is compiling it all. So here you find that AGP report is giving us what is the time of CGM applied, what is the glucose range, time in range, time above range, time below range, what is average glucose, and what is the glucose management indicator, GMI, which is just like a laboratory measured A1C. And then, of course, it gives us glucose variability. We want that it should be less than 36. Here in this report, it is 49%. And on right side, you can see this bar colorful diagram, which clearly highlights what is the status of a patient, looking into it straightforward. So clinical approach to CGM data is that if the time in range is 70 and above and time below range is less than 4%, then you don't need to do anything. You continue with the same profile of the patient. But there are 3-step process when you are looking into AGP: define the pattern and review the daily traces. So there are 3 scenarios here. HbA1c is another value, but here you find that the patient is having more hypoglycemic risk because the time in range is more than 50, but time below range is also more than 10%. And in next scenario, you have predominantly hyperglycemic risk where time in range is less than 50 and time above range is more than 5%. And similarly, you have predominant variability risk where time in range is less than 50 and time below range is more than 50. So in this situation, we have to make some changes in the lifestyle of the patient and therapy of the patient. So comparing HbA1c to time in range, HbA1c evaluates single hemoglobin value, HbA1c value. Time in range evaluates continuous glucose level. HbA1c compares every 3 months. Time in range compares any time period. And HbA1c does not capture hypo and hyperglycemic levels occurring in the same day, and time in range can capture all these glucose variations. HbA1c is having immediate effect on therapy change not recorded, and in time in range, immediate detect and acute effect of therapy can be changed. Bad correlation of PROs, and here there is a good correlation of PROs, and high susceptibility to interference substances are there with HbA1c, which is not there in time in range. And time in range is a good correlator of clinical endpoints and many long-term complications, but HbA1c. But time in range correlates to the endpoint, which is unclear. Hardly any long-term studies are there except few of the studies which Dr. Panda highlighted. There is a correlation between HbA1c and time in range. For example, if the time in range is something like 70%, HbA1c is 6.7, and if the time in range is 50%, HbA1c is something like 8.3%. So the another important thing in this CGM system is how to calculate glucose management indicator, GMI. This is a new term for estimating A1C from the continuous glucose monitoring. While we know that HbA1c is measured in the laboratory, but we can always extrapolate the mean blood glucose, which is derived from the CGM, to glucose you can say, management indicator. So it is basically a mean value of blood glucose which is determined by CGM, and there are formulas which calculate this mean blood glucose derived from the CGM into you can say estimated HbA1c. But there was always a confusion that on one hand we have a laboratory HbA1c, on other hand after CGM we have a estimated HbA1c. So the ADA says that we should change the nomenclature of this estimated A1c, and they have given a name of GMI, that is glucose management indicator. And this glucose management indicator is basically derived from the interstitial fluid glucose as compared to the glucose attaching itself to the hemoglobin in a HbA1c. So there is a direct correlation with CGM measure of mean glucose and central laboratory A1c. And you find that CGM derived mean concentration of glucose can be looked into, like if GMI is 7.5, the CGM values are, mean glucose values are 175. So if mean blood glucose is 250, we can say that the GMI, that is the estimated A1c, which is 9.3%. So there is some difference between estimated A1c and HbA1c. So there, most of the time in these studies, when they are comparing the two, they find that 19% time the GMI and HbA1c are having identical values. In 51% times there is a difference of 0.3%, and in 28% times there is a difference of 0.5%. So how to explain this to the patient? The important thing is that we have to tell the patient that on one hand you are measuring the attachment of glucose to the hemoglobin in A1c, and in glucose management indicator or estimated HbA1c, you are looking into the mean value which is derived from the interstitial blood, and then you are having calculations, and then you get a CGM, this glucose monitoring, GMI, that is glucose management indicator, or we in other words say estimated A1c. So dear friends, in summary, I will highlight that HbA1c was developed as a population based measure to assess the risk mainly, and over time it has taken on clinical significance in terms of diagnosis, treatment selection, adjustment of therapy, and assessing the clinical outcome. And HbA1c does not reflect hypoglycemia, hyperglycemia, variability, and measurement stability. And for it to be an effective measure of clinical performance, it must be accompanied by more specific measures of glucose control that provide a metabolic profile like CGM derived, you can say, ambulatory glucose profile. So dear friends, world is changing. On one hand, we have got so many information with HbA1c, but we have to complement it with time in range and other ideas from CGM data. So thank you very much.